biggest issue here with standardized testing for breast cancer patients with this genomic profiling is that we wanted to expedite this process so that we did reduce the anxiety the patients had between surgery and their medical oncology consultation. And it became a lot more clear which patients were appropriate candidates to be tested. When the NCCN guidelines were established for genomic testing, that made it a lot more standardized and clear for the surgeons as well as the pathologists and the medical oncologists to get together and team up and identify the appropriate patients to be tested. So we could initiate that testing with the definitive surgery when we're talking about just standard treatment and not the neoadjuvant setting. And our pathologists are very willing to join on because there are some issues with sampling of the appropriate block and that sort of thing. So your pathologist needs to be a big part of this. The surgeons, again, are the ones that initiate this anyway and communicate this with the patients. So we have to talk about this to our patients and let them know that we're going to take the next step in the pathology of these tumors to assist in their ultimate treatment. And then depending upon your program and your system, getting the medical oncologists on board too can be a bit of a struggle, but again, the guidelines help us out there, and they were very willing to participate. All in the process of speeding up the testing so that the medical oncologist and the patient have the information they need at that first consultation so that they can begin to talk about adjuvant treatment. And it reduces the anxiety and improves the process for the multidisciplinary approach. So we've been using a standardized order set for almost 6 months, I think. And it took a few months to get that organized. And I don't think we're reinventing the wheel with that process. I think there's a lot of other institutions in the country that are doing it and have already established good protocols and testing for doing that. Some of the difficulties in it, though, involve the node positivity area, which can be a little bit complicated. The NCCN guidelines are established for micrometastases, less than 2 millimeter metastases. I would think that you'd want to know the information. This is too complicated of a treatment area for, I mean, we can't expect our patients to understand this. So, and their friends and their neighbors tell them what to do instead of sometimes their doctors being able to tell them what to do. So they come in with these preconceived ideas about, I'm not going to get chemo. And they don't even know why they're going to get chemo. But why wouldn't a patient and the physician taking care of them, why wouldn't you want this information? It's a guideline, just like the guidelines are established. You don't have to completely use it to determine your treatment, but why wouldn't you want to know what this information is so you can appropriately counsel the patient on what might be the best, whether they've got their preconceived ideas about what they want. But to me, it's a lot easier to show someone a graph and what their recurrence score is than to start talking about how big their tumor is and the node positivity and start discussing a bunch of clinical trials. I think they can understand that recurrence score pretty easy.